Good afternoon, everyone, and thanks for attending today's ACAM's eMedTalk with Dr. Ahvie Herskowitz, President of ACAM, providing an update on the global pandemic of the coronavirus and offering valuable insight into what impact it may have on your life and health. Attendees are encouraged to submit questions using the chat box to the right. Questions will be addressed throughout the presentation with a longer Q&A at the end. Registrants can expect to receive a recording of this presentation within 2 to 3 business days via email. So next, I'd like to introduce the moderators for today. They're going to be Dr. Howard Hinden and Dr. Pat McBride. Dr. Hinden, President of the American Academy of Physiological Medicine and Dentistry, is well-trained in all aspects of general dentistry, and since the 1990s, actually has pioneered the relationship between dental issues and whole body health. Sharing that same passion for a better understanding of the connections between dentistry and the whole body health, Dr. McBride has relentlessly pursued improvements in the fields of dentistry, respiratory medicine, and dental sleep medicine. It is such an honor to have both you guys here today, and I'll pass it off to you, Dr. Hinden.
Hi, everybody. I'm Howie Hinden. I'm the current president of AAPMD. I'm also the vice president of ACAM and had the great fortune to work with Dr. Herskowitz and through our mission of Collaboration Cures. And let me bring on my co-host, Pat McBride. I'm in New York. Pat's in California. Hi, Pat.
Oh, great. Thanks very much. Howie and I have been doing this for the last couple of years, and we're very excited to have Dr. Herskowitz with us. I come out of respiratory medicine and dental sleep medicine and work towards developing interdisciplinary care provision for the underserved patient, as well as providing access to care to hypoglossal stimulator implant patients.
So, Jordan, if you put on the intro slides. So, as I was saying before, a number of years ago, ACAM and AAPMD got together and had a conference, and we titled our conference Collaboration Cures, because we realized that no one discipline has all the answers for the chronic, really the epidemic of chronic health problems we have. And so we had a conference, and that conference has really become a movement with more and more organizations joining in, and it's growing. And this whole pandemic really speaks out to the need for a Collaboration Cures movement. And as you can see, we have more and more organizations who are affiliated with this movement, and it's growing, and it's fantastic. And there's never more need than is now. I thought I would share with you some of the upcoming events. And you should know that at least one of them, you're going to be registering for that at ACAM. So next Tuesday, we have a presentation with Dr. Dave Singh on airway remodeling, which is using certain dental appliances to actually change the size and shape of the airway and provide for better breathing. Next Wednesday, we have a great webinar, and I'm going to let Pat talk a little bit more about that with Dr. Savante Saib, who is a provost and doctor of psychology at Purdue University, talking about losses and gains and grieving.
You.
You're back. Can you hear now? No, still not.
Yeah, I can just hear you now. Thanks. I lost my internet connection there for a minute.
Pat recently got a PhD, and one of her mentors was Dr. Savante Saib. And why don't you just tell the audience a little bit about what that webinar is going to be about?
Oh, Dr. Savante Saib is probably the most famous for having invented or discovered the loss gains theory that has a lot to do with how we perceive losses and gains for every major event in our lives. So we felt it was very important that somebody with her background come and talk to us, because not only are we as individuals and practitioners dealing with our sense of losses and gains and grief with our lives, with the COVID, we're also, it's not just about having somebody die. It's about portions of your life and your day-to-day encounters with other people and the loss of one thing, but what do you see as a gain and how can you take that forward, moving forward, and then help your patients who may be presenting to your practice with, gee, my tooth hurts or my jaw hurts, when essentially really what their issue is has nothing to do with it, and to help you kind of better see where you might be able to intervene and to be of great service to your patients by kind of understanding this. So she is absolutely delightful. She's so insightful and can't wait to have her on. She's going to be wonderful.
Yeah, and I'm sure that patients that we're all going to be seeing as we reopen our office are going to be dealing with issues related to that. And it may not be a sleep airway issue. It could be something related to just what they're experiencing in life. And then on June 17th, we have a presentation by Lisa Fina and Nancy Weiser, who are both health coaches and on the board of a group called Sharp Again Naturally that educates the public about the reversible causes of Alzheimer's, memory loss, and dementia. And they're going to talk about the work they are doing, plus the important role that the health coach plays in our movement, because somewhere between the practitioner and the patient, health coach has a very important role in order to coach them through the changes that their practitioner has advised them to make. So mark that on your calendar, June 17th, 8 p.m. Eastern time. And then a week later, June 24th, we have an exciting presentation about the growing role of hemp and CBD oils for our patients, which is fast becoming accepted and very beneficial. And there's a lot of information about that I'm not even familiar with, so I'm looking forward to that. Anything you want to add to that? Or let's go on and to our next slide. I can do that.
Move on. Mm-hmm.
Right. So
Thank you.
our message to you is we want you to be a partner. If you're a practitioner, we want you to be a partner in our mission of Collaboration Cures. Join ACAM. Go to www.acam.org or come join the AAPMD, www.aapmd.org, and become a member of what we're doing. And if you are not a practitioner, if you're a consumer, join the Foundation for Airway Health, and that's free, where you can get a lot of information. And a lot of information on all of the websites are free, but we encourage you to support our mission and become a member. And so Pat, I'm going to ask you in a minute, I'm going to ask you to introduce Ahvie. I just wanted to add that Pat and I have been talking. She's gotten over 50 calls of people asking by the next presentation, next one of Dr. Herskowitz updates. And I am so proud and fortunate to work with Ahvie. And he's one of the brightest and caring practitioners I know. And I'm very happy to have him as a medical advisor to me personally and as my friend. So Pat, I'm going to turn it over to you.
Thank you very much. I'm just trying to find Ahvie's president of ACAM and one of our sister partner companies that we work with. We're very excited. International leader and educated in the field of personalized precision and integrative medicine, with an active background in cardiology, immunology, autoimmunity, and virology. So wide swath of the medical spectrum is at really the heart of understanding how inflammation affects our lives. And his most recent clinical academic standpoint has sent us here. And he has a clinic in San Francisco called Anatera Medicine. And he's the founder of the SF Stem Cell Treatment Center as well. So clinical professor of medicine at UC San Francisco from 2014, and a president of ACAM for the last few years. So welcome, Dr. Herskowitz. Let me not take up a minute more of your time because everybody wants to see your slides and hear your update.
Okay. Thank you, Pat. Thank you, Howie. I think we just need to get started, because everyone wants the update. So I'm going to just do that, and we'll leave questions to later, and interrupt me if you lose me. I think my audio, no matter what, will be left intact, but my video may come and go. But the slides are going to be seen. Today, I'm going to be interested in giving a perspective on where we are. Last time we did this was around a month or so ago. Things have changed dramatically. They've evolved over time. And of course, we have the unique characteristics of what's going on now with the protests in mind and how this will affect the pandemic's future in the United States in particular. But I wanted to ultimately get everyone at the end of the day to understand their own personal risks and their own personal strategy of getting through this as well as possible. So let's just start with some basics. This is where we are relative to other folks around the world. If you see the bar graph from the major European countries, in orange, you'll see that per capita, you see the United States is relatively in the 6th place in the world in terms of deaths per 100,000 persons. It's roughly 30, which roughly means around 1 in every 3,000 persons in the United States. Roughly, again, 300 million people and so on. So it's roughly 1 of every 3,000 persons. And by the time we're done with the presentation today, I think you'll understand where you lie or where your loved ones lie in this type of formula. One of the things that's really striking is the difference between the European countries in terms of death rates and the Asian countries. It's almost as if they're two different diseases and then treated in two different ways. Since there's no treatment for COVID-19 that has been used, it begs the question of whether the viral mutations in Europe played a significant role in this. The other thing in the European countries, if you take a look at Germany, Germany was around 5 to 8-fold more efficient in not allowing patients to die relative to the other European countries. And right now, we frankly don't know why. But this needs to be studied over time. When you look at where we stand relative to the ground zero in the United States, which was New York, you realize that New York was ground zero for the entire world by a factor of 2 or 3, or relative to the highest prevalences in Europe. And then relatively, since I'm based in California, I like to use California as a benchmark for below average risk relative to the other states in the United States, but seeing that there's a 15-fold difference between New York State and California today. And California is roughly the same prevalence of mortality as Germany, for example, is, but significantly higher than all the different Asian countries that are listed. And again, we're not quite sure exactly why, but I think the hypothesis that the virus itself was fundamentally different also playing a role here is probably needs to be examined very, very thoroughly going forward. So when you look at how things used to be in middle of April, they didn't look very good. So when you look at the peak in mid-April versus 6 weeks later or so now, today in early June, these are 1 week average deaths per million. So when you look at, for example, Belgium, which has the highest prevalence in the world other than New York City, and New York State, that is, it's roughly about 15-fold increase at the peak versus now. And you can see the remarkable progress that the virus has done, as well as the caregivers in these countries have accomplished over time. So below 1%, I think Spain is a typo. It's something like 0.2%. The UK and USA and Sweden are a bit higher. But what's interesting here is to track and keep in mind the Swedish experience, which was which was a hybrid experience relative to the rest of the world, and roughly had a higher peak than the United States, with less social distancing and less sheltering at home than we did, and kept schools open. But the death rates are roughly still a little bit higher than we are in the United States, but never reached the peak of the other countries in Europe. So when we examine where we were in those days in middle of April, where the death rates were climbing at their peak, if you estimated on the daily mortality rate at that time, and you estimated how many folks in the United States would die from this disease, you'd end up with an estimate of 950,000, which was, would have been a disaster, of course. But ultimately, things come under control, and in just a few weeks, the estimates go down to a rate of 650,000 in the United States, which would roughly be the same as the death rate from heart disease in the United States. But even a month later, we're almost half. And then based on multiple sets of projections that from different databases, you'd project that right now we're annualized in a month's time, we'll go down to 180,000. And as you may already know, we're at 109,000 now. And then sequentially over the next ensuing months, would go half down further and further. Ultimately, if you want to benchmark, we have around 50,000 suicides in the United States every year. So as we have the mortality rates 2 more times, we'll roughly estimate the prior death rates from influenza and suicide. So right now we're going in the right direction, it's clear, but let's see exactly where we stand now. So as of today, we have 109,000 deaths in the United States, and that's roughly 330 deaths per million, or 1 in every 3,000 persons. And that's roughly 4% of the total death rate in the United States of 2.8 million. So it's really a relatively minor bump, but this is, the data is not really well presented here, in the sense that this is only 3 months worth of death rates from COVID, and then the annual rate of 2.8 million is 4 times that amount. But relatively speaking, when you combine COPD, severe lung disease, pneumonia, and flu, it caused roughly double of that, or 226,000 deaths. So even if we go to COVID deaths, which are two times higher by the end of 2020, which is a reasonable estimate, it'll roughly be equivalent to the 2018 death rates for COPD, pneumonia, and flu combined. This is relative to some 3 times that amount of annual deaths from cardiovascular disease and cancer. Again, this is just to provide a perspective for all of us. It's not the absolute risk is not 1 in 3,000 for each and one of us. Everyone has a different relative risk, and I'm going to go into that in quite an amount of detail. So when you look at it from a bar graph perspective, it looks like this. And so estimating at the end of the year at 200,000, then it is relatively less than all these other phenomena, including Alzheimer's, stroke, COPD, and unintentional injuries, and roughly double, 3-4 times the normal influenza and pneumonia rate. So how do you deal with relative risk? I think all the members on the webinar already know this, but I need to emphasize certain points. One is, of course, age. We all know about that, but we all know that certain folks are not simply a function of the biological age. They're a function of the pre-existing conditions. And since the entree of this virus into the body is fairly unique, through this particular receptor that modulates so many different functions of inflammation and fluid balance and lung disease and so on, it's really a function of the pre-existing conditions that tell you that the ACE2 receptor is already not functioning properly. It's also, of course, the region, because we know that there's a dramatic change and the dramatic emphasis of this virus in the East Coast versus the other locations around the country. But now it's becoming clear that race and standard of living are important components. We know that African Americans are at 2 to 3-fold increased risk, and so are Hispanics and so on, relative in terms of race, and also issues of access to medical care and medicines are also a function of standard of living. So, of course, these are factors involved. Now, depends on where you work and where you live. You know, if you work in the hospital, then you're going to be at greater risk. If you're a prison mate and so on. But I'll show you in a moment about roughly 40% of all the deaths in the United States occurred in nursing homes. That's a staggering number. I think it's 46,000 out of the 109,000. And when you count the staff and also count assisted living facilities, it's going to hover around 50%. Now, this is a very, very important slide, and I want to take a few minutes. I hope everyone can see it well. This is the 3-month period from February 1st to basically early May. Over February, March, and April, the CDC data put together U.S. deaths by age group. And the whole population and all ages are on the top row. And you see at that particular moment in time, some 1 month ago, we had only 60,000 deaths, but the proportions are likely going to be the same. So at that particular point in time, COVID only represented 7.4% of all deaths. And actually, from a different database, we had, over this period of time, we've seen 4% more deaths than we anticipate in any other year. So it's relatively a small input into the larger total, but the total is fairly stable across all age groups. Now, when you look at the bottom row first, you'll see that 80.33% of all the deaths occurred in the age group of 65 and greater. I just lumped them into one. As you all know, greater than 75 and greater than 85 are even higher and higher. But 80%, or if you look at the next row, 92.5% of all the cases occurred in the age 55 and above. So when you say that, relatively speaking, 4/5, 80% of folks are in that group, and then we'll have to tease out what is so impressive about that group that they would be so susceptible. But then you look at the first real data row of less than 24 years of age. There are only 78 deaths in that group. Now it'll be higher because the deaths are 109,000. But relatively speaking, 0.1% of all the deaths occur in that group. And we know from another set of data in a minute that I'll show you that the majority of these kids under the age of 24 had pre-existing conditions. But when you look at the 104 million in the population that is less than 24 years of age, you're dealing with less than one per million at risk of death in that population. So when you look at the difference between 78 in the less than 24 group and 48,000 in the greater than 65 group, in this particular way of looking at the information, you'd estimate that there's a 650 some odd increased risk in one age group versus the other. So if you're 65 and above, you have 650 times more higher risk than if you're under 24. And this, of course, it has to be dealt with when we deal with the kids going back to school and to not just the kindergarten and preschool and to grade school, but also through high school and university. But when you look at the difference between 55 and 65, it's around 7-fold. And it's around 12-fold for the 25 to 54 group. And so it's really an issue of age. And that's a big driver. But of course, within the age groups, you have to analyze what's going on. But in certain groups, you could argue that in the bulk of the population, in 132 million people and below the age of 54, the risk is quite low. So 99.87% of deaths occur greater than 25. There's a 36-fold lessened increase if you're in that younger age group from another data set. This is another CDC data set. They don't all overlap exactly with age groups. And then there's a 600-fold lessened risk versus in the youngest population versus the oldest population. So when you look at one of the problems of understanding what's really going on is what is the real prevalence, and what's really remarkable and annoying to epidemiologists or folks that are interested in population data, as myself, is what is the true prevalence? You have to do random sampling. There's only been a few little sets of information to go by. So in San Francisco, 6% of random samples were positive, but it was just done in one neighborhood. And then in New York State, 15% of people randomly sampled in the population were positive. So that's 20 million persons. That means that there were 3 million true positive cases, and yet there's only 380,000 confirmed positive cases as of today. So that's around 8 times less than the true number. This has been consistent throughout the Asia and European experience, that ultimately the numbers of positives that you pick up are roughly 5 to 10 times lower than the true positives. So if, as of sort of, I think a day or so ago, 30,000 deaths in New York State, well, the true risk with 3 million true positives would be about 1%, or 10 persons in 1,000. Now, we'll get into this in great detail later, but I just wanted to give you a preview of relative risks. So we know from information that's coming forward from Europe and from Asia that having simply normal vitamin D levels reduces your risk by actually up to 8-fold, and I try to be conservative, and I said 4. And so ultimately, that's going to be 2 in 1,000 patients. And then you can say, well, if I don't have any one of these pre-existing conditions, my risk is further reduced by 4, and then now it's 1 in 2,000. And then if I'm less than 65, my risk is reduced by 8-fold, and then I get to 1 in 16,000. And ultimately, using this type of information in this particular way, it's around 1.3 persons per 100,000 in the under 24 group. But looking at it from the other way that we just had before, it was closer to 78 out of 104 million. So it's roughly a 1 in every 1.5 million people. So it's really dramatically important to understand this. And I'm still startled every day why this is not being discussed throughout the press. So then you say, well, okay, I have a certain age things, and I'll review my relative risks relative to laboratory information and relative to disease pre-existing conditions. But it's also, this is a regional disease. When you look at the differences between Asia and Europe, it's clear as day. But then within the United States, you look at the ground zero, which is New York and New Jersey and even Connecticut, versus the other 48 states. You look at progression over time. So this is the cumulative death rates over per million by the regions. And you can see that versus, for example, New York, New Jersey versus California, in the red, it's around 18-fold difference. And versus, because the California rates are slightly below the national average. And the top 10 states, of course, are about 4 or 5-fold less than the bottom 40 states. So it depends on where you are. And this, of course, leads to different regional decisions that are made by the public health folks and the mayors and the governors. So when you look at the state-by-state things, you realize that New York had an immense peak. So did New Jersey and Massachusetts. So these are the top 5 states, and then California, just as a comparison versus what it is now. So what it means by now, let's say 4.9 would mean 5 persons per day would die. So that would be roughly around 1,700 people, 1,800 people a year, and that's not going to happen more likely than not because the progression over time is going to be lower and lower and lower. But you can see that certain states still have a lot of work to do, like New Jersey, Massachusetts, and so on. But California is relatively low at this point, but even 2 persons a day is not exactly an acceptable situation. So as time progresses over the course of the next month or 2 months, we'll see the slope, but we anticipate ultimately, I anticipate being at a steady state in 2020 at 200,000, and then going further into 2021 to be significantly lower than that. And then Pat and I spoke earlier about the impact of the demonstrations, and we'll talk about how that may impact on this. So when you say, okay, I understand certain risks and certain regions and certain age, how age impacts my risk, but what is this? What's going on here? So this particular virus enters the body through a receptor called the ACE2 receptor, and that receptor is responsible for many, many bodily functions and is present on every blood vessel in the body. So it can go everywhere and anywhere depending on the concentration. So we know the concentration is higher in the lung and the heart, but in blood vessels throughout the body, and that can cause an overwhelming amount of different states of being, depending on the genetics of a person and depending on how inflammatory that person is, or which organs get manifest with the worst overall disease. But it's a total body, total system effect when you're symptomatic. But as you will see, that most of the folks will remain asymptomatic or very subtly symptomatic over time. But you can have every organ involved. But when you look at the information from New York State, this came out after the first 5,000 some odd deaths in New York City, in New York State, but primarily from New York City, published in JAMA. If you look at the pie charts, the orange part is the greater than 75, and then the brown is 65. When you combine the two of them, it's roughly 47 and 24. I wish I had a pointer, which I don't. So it's roughly about 70% of all the cases are above 65. And the data right now, nationally and regionally, is 80%. So you also have the number of folks in there, the proportion of the folks in there that had pre-existing conditions. And you see that roughly 70 to 85 or so % of the cases in those age groups, and even higher numbers in the 45 to 64 year group, have pre-existing conditions. That really means that if you're 50 years old and you have prediabetes, obesity, hypertension, and heart disease, you may be more susceptible than a 68-year-old person who doesn't have any of those symptoms or pre-existing conditions. So as a summary, I've shown this before about a month or so ago. This is tedious to read, but it's really, in this case, 88% of the patients hospitalized in New York City had greater than 1 or more, and half of them had 4 or more. And again, those tend to be, hypertension is number 1, obesity is number 2, diabetes and heart disease are 3 and 4. And what was striking is that most of the patients never smoked, and only a small number of them had asthma and COPD. So it doesn't directly target those folks with pre-existing lung problems, but rather with those problems that tend to be inflammatory in nature. So once the virus enters your body, it's up to your own system's ability to modulate its effect to warrant whether you're limited to a sore throat or no symptoms at all, versus having some chest discomfort up to shortness of breath, and then ultimately more serious complications of coagulation and clotting and so on. So what is public health right now in the United States? It's using a massive amount of information that we're all deluged with every day. As we've learned the new terms: flatten the curve, keep the numbers of infections low, and allow the surge capacity to grow. I think that it is crystal clear that New York City almost met its limit with surge capacity and almost got there, and thankfully it closed down soon enough to avoid that, and all the heroes and workers there are to be considered again, heroes of the entire society there. But this isn't, it isn't rational to just think about this by keeping new infections low, because in every society in the world that has opened up after the big surge happened, they have additional cases, and that's to be expected because this virus is not going away. It doesn't work like that. Over time, it may diminish in terms of seasonality and temperature and whatnot, but there's no clear reason to believe that just because you keep infections low by having all the folks staying at home, it won't, as soon as people come out, they won't get infections. The question is, what is the risk of any given population to get there? But it's limited to the talk about how to limit exposure, as if vaccines will come in a short period of time, which are very, very unlikely, and that will save everyone. But when you look at this, the virus is not going away. We will have a tail end, and we will have other minor waves, no matter how you swing it. And we need to get the therapeutic trials to be completed. And I don't mean the remdesivir, which is an IV formula, which I'll describe in detail later. I mean some oral antivirals that can be 50 to 70% efficacious. They'll be game changers. And there are candidates out there that you probably are not even aware of that I'll review in a few minutes. So, but the only rational approach, in my opinion, is to consider a long-term immune modulatory strategy. That's antiviral, it's pro-repair, pro-metabolic, and so on. So the goal is to catch the virus and remain asymptomatic or low-level symptomatic so that you don't need to have a vaccine later, and you won't have to be part of that whole discussion. That's obviously the goal, and have public health officials concentrating on reducing the rates in the high-risk environments. You know, if we had a COVID czar for nursing homes and for prisons and so on, and for meatpacking facilities and for work facilities that are unacceptably can't follow social distancing, then we would be in much better condition today. So this is just to emphasize that the cases are not going away. I mean, as you ultimately measure the virus load in all patients, in all people in the United States, it will be continuous. It may drop over time, we're yet to see, but it's there. It's not going away. And then in New York, it was so dramatically high that it's now in a fairly steady state as well. But again, this is just to emphasize the point that I don't think anyone should rationally believe that in a month's time, in a weeks to a few months' time, that the virus is going to disappear. So even in societies that I want to thank colleagues in Drs. Park and Watarai and in Korea and Japan respectively for sharing the details of their country's response and the details to their country's impact. So this is schools in Korea, which were reopened around a week or so ago in various different forms. The one on the left was meant to say this was a bit, draconian because the kids can't see each other. And then the lunchroom, and on the right, you could see this is sort of what we can expect in the United States, and yet the schools are largely closed a week later because they had a surge in cases, but that is irrational, in my opinion, because you expect cases once you get the kids together, because not all the kids will be wearing masks, and they will be they're not going to be able to social distance all day. But the question really is that led to anything? And of course, in Korea, they have less than 300 deaths for 80 million people. So they have an exceptionally low mortality rate, and that mortality rate has not budged at all ever since they opened their society. The only thing that they found was a surge in cases after a nightclub was opened, after a sort of opening night where everyone spent all night dancing and singing and drinking, that they had a large number of cases. But again, no surge in deaths, just surges in cases, which are to be anticipated. So We have a very limited public health strategy in place. There's no metrics. Every time I hear in San Francisco that all we need is protection, surge protection, and getting the numbers low. That was 2 months ago. We met it a month ago. We met it. Now we still have met it, and then we still are fairly much locked down. So there's no real rational perspective. There's no focus on the high risk groups at this time, and there's no random sampling across the United States. And there's limited contract tracing, so we can't mimic the situation that took place in Asia. We just can't. At the same time, it's unclear whether that would make a huge difference over time, but it certainly would make things improve. But this public health system is not really firmed up at this point. And there's no antibody testing to the general public to know who's already been infected and what's immune. I really don't have the time to go over the vagaries of the testing, whether the testing is for the RNA of the PCR test, the swab test, versus the IgG, IgM tests. But suffice to say that there is no clear evidence of reinfection at this point, and there's no clear solution in terms of a single test to use nationally. So we're going to get variable results depending on what tests and what the sensitivity of the tests are, and that's not going to go away. So you say, well, okay, what have we learned from the virus in the last month or so? So we've learned that there are predictive biomarkers. So what are they and what do they mean? And while I don't have time to review them all, you could see for those of you that are practiced in this, and all of those of you that are good with supplements, you'll notice that vitamin D is on there. That's probably the single most important public health comment that I have today to make, that if you normalize your vitamin D level to above 40, or better yet, above 60 to 80, or even higher, the better off you'll be. But then there's a coagulation marker called D-dimer. There's an inflammatory marker, fibrinogen. There's a marker for oxidation, and then a general marker, ferritin, and then a general marker for C-reactive protein. All these are all fit the inflammatory model. And the model that you need antioxidants to deal with this type of disorder if you're going to get exposed. And if you get exposed, you'll modulate the risk that you develop over time from complications. So so it fits the inflammatory model. So when you say, well, what other evidence do you have, and so on, I don't want to show you I have no time to show you the risk, the enormously increased risk of dementia patients, which dementia is a neuroinflammatory state. But when you remember this slide that I showed you and memorize it for just a split second, and I'll show you the next slide now, you'll see that it mimics the obesity problem. So when you look, relatively speaking, to the Asian population versus the developed world in the West, you'll see that these two fairly overlap. So there's a dramatic reason to believe that obesity, which is also an inflammatory state, plays a role, but it plays a role because it signals an inflammatory state. So the ACE2 receptor, I think we've gone through this before, and I think we also want to make sure we stop for questions. But the bottom bullet is the most important, and COVID makes all these disorders worse, and many reach a tipping point that cannot be reversed, and that leads to widespread coagulation and clotting, a widespread injury to the lungs and hearts that are permanent and irreversible. So, but again, it's the wake-up call of the virus that tells us that these other states are inflammatory and we're at risk. But interestingly enough, the things that increase the ACE2 receptor, which means that the virus has more receptors to attach to enter your body, like ibuprofen, the ACE inhibitors, and the other antihypertensives called ARBs, they do not increase the risk of infection or death. So it indicates clearly to me that once a person gets infected and they're not increasingly infected by ACE2 receptor density, then it's an issue of how your body will respond. In other words, how do you control your own response? So then you have all the things that most everyone knows about. Vitamin D, vitamin C, you've heard this before from me and many, many others, things that are immune modulatory. Colloidal silver as an could act as an antiviral, it's just an antimicrobial. All these things, the glutathione, which is an antioxidant, alpha lipoic acid. These are all modulatory strategies that make sense. There's a lot of information. It's not COVID related, but a lot of prior information, and I'll show you in just a minute. But then we have the magic of hydroxychloroquine, which is also immune modulatory and antiviral, but all studies have been stopped because they increased deaths in the later stage patients from heart problems, from heart arrhythmias. But I believe that we may get some clinical information based on earlier studies that have not that enrolled enough people to say something, but they have not been published. Because the real way to give an antiviral here is to give it early and to give it orally. So there is another antiviral on the fourth bullet there called Avigin from Japan, which you all need to investigate. There's no access to it at all. I tried to get it from Japan as soon as this pandemic started, but the government locked it down to even the Japanese physicians who could not prescribe it. But this antiviral was created for MERS and SARS and has a COVID efficacy. But the only group that has said anything about it has been the Russians, who came out with some literature a day or two ago that said that it reduces viral load in 4 to 6 days. So we need an oral antiviral, and it is not likely to be hydroxychloroquine in the United States because the studies are not going to happen. And then the remdesivir thing that I'll talk to for a few minutes is discouraging and is only for IV use, so it's too late. It doesn't make me warm and fuzzy inside to say that I'm going to be given an IV drug once I'm intubated. I don't want that. I want a better solution. Statins appear to reduce the risk, which are that's not unheard of because they have anti-inflammatory effects. And I'm not going to get into the details about the biologicals, the peptides, the stem cells, but there's literature going to be out there. Again, we want preventative, we want early and preventative strategies. So Dr. Sinclair was a giant of internal medicine, and he said the following statement: "It's so obvious that you need to provide yourself what you're deficient in terms of nutrients, but that he's continually astonished by the fact that it has to be restated all the time, and that's no different than current environment for vitamin C and vitamin D, certainly. But human nature is such that simple solutions to complex issues are often overlooked, and this comes from some literature that just came out. And again, it's disappointing, but it's consistent. So vitamin D has been shown, and there are binders in my office on vitamin D. Suffice it to say that there is data now coming from China in particular that showed that there was an 8-fold increased prevalence of people with abnormal vitamin Ds who were hospitalized in severe condition versus others that were not. So it clearly needs to be validated in larger studies, but this is clear that it should help you. And everyone on this call should make sure you know what your vitamin D level is and get it to normalize. And again, the goal is above 60. And then you have this, say, well, ARDS looks like sepsis to the intensive care unit doctors, and there are a lot of unique features to COVID, but just let's assume for the time being that there's something similar. Around 2017, there was a study that showed that IV vitamin C helped, but it really never took off. So in 2017, Dr. Merrick did this study, this small study, and then it never got taken up by the NIH and others. But then he repeated his study back in just a few months ago in pediatric patients and showed that that there was a 3-fold reduction in death rates from the pediatric population treated with IV vitamin C and steroids. So I think that there are protocols now in the country and around 5 or 10 of the centers across the country. Presumably we'll see what their results are once they're published, but anecdotes are such that the patients are doing significantly better on IV vitamin C. So no, we can skip this. I think, but then you go to Dr. Fauci, our lead medical expert on this area. So what's going on here? He says, listen, I don't want to hear anything except something that's randomized and controlled. And if it isn't, it's off the table. Well, that spectacular demonstration that he gave in the Oval Office a few weeks ago never followed those guidelines, his own guidelines with remdesivir, where he suggested there was less hospital time in the intubated patients. And again, it had no impact on mortality. And it contradicted a prior study in China, which was a randomized controlled, placebo-controlled trial, which he says is definitive, and he ignored it and said it was underpowered and not adequate. In any case, that was remarkable to the academics in the audience, to us who know clinical trials and understand what he was trying to say, where he said this is the new standard of care and we should stop all clinical trials in other areas. But it's a moot point, because another larger trial by Gilead is just published a few days ago and showed that it had essentially no significant benefit in moderately ill hospitalized people. So ultimately, it's not going to be a big deal one way or another. But then he managed to say that hydroxychloroquine shouldn't be used anymore. And then that was done by this very strange article that came out in Lancet in May of 2020, which was weird because it's a collection. It's not a randomized trial. It's a registry of multiple hundreds of hospitals with 90,000 patients. And no one's ever heard of that database before. I certainly haven't. And now there are, I think 140 scientists wrote to Lancet asking to validate the study and find the raw data, because no one's ever seen that data before. So this has to be played out in the real world over the next few months. But the conclusions ultimately are the following. I mean, I can spend a whole hour on conclusions themselves, but it's a wake-up call. It's a nature wake-up call for us to evolve. Not only us to evolve as our own consciousness and figure out how to help each other, but also how we can wake up to the deficiencies that our lifestyles are producing in our system that cannot deal with this particular virus if we have certain deficiencies in nature. So nature is asking us to evolve, and they're also asking the medical system to evolve. And I suspect the medical system is not necessarily prepared for this, but it's not going away. So we'll have to figure out how to deal with it as individuals and within our families. But the main message is, the only sensible message is to get your own health in order. So while we're doing this, pharma is convening vaccine-oriented meetings with special guest speakers like Fauci and CDC. When you look at these folks that are sponsoring these meetings, it's clear that this is preparing paving the way for vaccinations and perhaps even forced vaccinations over time, because this will be the saving grace when we already know that the risk for certain groups are extraordinarily small, and the risks can be mitigated by simple things like vitamin C and vitamin D, and certainly if you're God forbid ever hospitalized, even intravenous vitamin C, which is again exceptionally safe. So these things cannot be avoided to be discussed in open dialogue, because this is clear that this is not going to be the only solution. And I could spend another hour the next time I'm here to talk about viral drug development, in this case vaccine development, and show you how difficult that road is going to be over time. One of the obvious things to ask is, well, if some of the Asian countries have 10 to 100-fold less mortality than we have in the West, then perhaps the mutations are different. And then which vaccine are you going to use? Are you going to use the one that's suited for the Europe and US, or are you going to use the one that's suited for Asia and so on? It's not easy to get all the different mutations covered with a single vaccine. So my last slide here today, I appreciate everyone's time and patience with this, is the founder of internal medicine in the United States, which was the first chief of medicine at Hopkins, my alma mater, said that young physician starts life with 20 drugs for each disease, and the old physician ends life with 1 drug for 20 diseases. And this is really what we need to figure out. We need to figure out how to get ourselves living an anti-inflammatory lifestyle with nutrition, with exercise, with intermittent fasting, with nutrients that we're deficient in, such as vitamin C, vitamin D, and glutathione. And then we need to observe, document, collaborate, share, and teach. Thank you.
Amazing. Thank you so much, Ahvie. Really appreciate it. So I know that a lot of the people attending are probably concerned with what your thoughts are regarding one, the lack of social distancing with all of the rioting and things that are going on, and how you feel that might attribute to a profound increase in cases that might jeopardize everything good that's been going on in this short term.
Well, again, if you look at the trigger points that the Asian countries have lived through, where they open societies up, like the famous ones that we're aware of is Singapore and Taiwan. They had a few deaths and they shut the whole country down again, and that's to be anticipated. So if we have that same trigger point that says, listen, we have 15,000 people gathering and talking all night and spending all night out and not social distancing, yes, you're going to see an increase in cases 2-3 weeks later. But the question really is whether you're going to see an increase in mortality. And none of these Asian countries have seen that. That's largely because the people who go out first are the ones who are younger and healthier. But you're right, it could be used as an excuse to shut things down again. And we all hope that doesn't happen. But we have to say, what's the metric? What are we looking for? We're not worried about another true surge. That no one has experienced, and I think that's very, very unlikely. But we are going to see different waves of positive cases and waves of a few hospitalizations. In certain parts of the country more than others, but there's so many different factors involved. There's no way to estimate, but you should expect some cases to be positive in all these different locations 2-3 weeks from now.
Great, thank you very much. I think one of the, Howie had a question.
Dr. Henry, we're unable to hear you.
How about now?
Yep, good to go.
Okay. I'd love to have you up and giving the daily press release to the country. So listen to you talk. 50% of people are nursing home related of the deaths. We have an economy that has completely come to a close, and there are people who are probably going to suffer a lot more because of the damage to their loss of income, loss of business, and because of what's happened to our economy and trying to achieve a balance. You also say that there are many more people that have been tested and found positive who probably had the virus and never knew they had the virus.
That's correct.
And so, and there are ways to protect yourself against getting a severe case by doing things that are anti-inflammatory. What would be if you were in charge, what would be your best advice for our country of how to proceed forward?
And
then we'll put you on the ballot.
Yes. Well, I think it's fairly clear, as I said before. We cannot expect the public health system to understand what needs to be done on how to optimize your ACE2 receptor is not their gig. It's not their thing. That's for integrative doctors, integrative dentists, people who are interested in aging gracefully and understanding optimization. But you can't sit around. If the number one early signal that vitamin D is effective, then of course getting into the sun is important. But then you can't go into the sun if you're locked down in your house. So you need to have your plan, and I think that if you have, the question really is whether it's rational to subject the less than 0.1% of the population to a certain type of lifestyle over the next year to save folks that will get hurt by it. And I think that at this point, everything that we've learned is that has to be discussed. But how do you protect yourself? You protect yourself by making sure that you take on the external side. If you take multivitamin, multimineral, you could take vitamin D, you could take glutathione, you could take alpha-lipoic acid, you could take anything that you feel is supportive of your immune system, and then you need to eat, proper food that isn't inflammatory. It says stay away from the processed sugars and so on. And then for me the easiest thing is take vitamin D and do intermittent fasting. I mean, that those two things are fairly easy to accomplish and will put you in repair mode much more rapidly than anything you could take externally other than that. Yeah. So that's what I would say. And then they'll say, well, where's the placebo-controlled double-blind trials that vitamin D help? But they're all observational. But that data will become clear, and hopefully after this is dealt with and all that information is out, we'll be able to clearly send the message across the entire country that particular blood test is a pivotal one for everyone's health over time.
Yeah, and the what our Collaboration Cures movement believes in is things related to food, diet, nutrition, sleep, airway, and breathing, movement, and exercise, and have some degree of stress management, mindfulness. And the other factor is having the patient a partner in the treatment and taking charge of the health. The other option is to stay at home, locked up, wait for a vaccine to come.
Yes.
But what we see in all the integrated medical and dental practices, the same conditions that make you susceptible to severe COVID cases are exactly the same ones that lead to all the other things that integrative physicians are treating: the diabetes, the cardiovascular disease, blood pressure, and chronic pain. And this is a wonderful opportunity. I read a survey today that said 80% of adults will be more involved in self-care now than they were before. They're really realizing that the medical system isn't going to be the salvation to their healthcare problems, and it may really ultimately make our healthcare system better and our population healthier.
Yeah, and I think you mentioned before about sleep and airway. I think that most of the doctors out there don't appreciate the relative importance of that. You cannot repair yourself at night unless you're sleeping properly and you're breathing properly. And that affects blood pressure, it affects all your sympathetic nervous system, it affects stress levels and so on. So I think that for those folks on the webinar that are the public, you have to understand that going to an integrative dentist is no different than as important as going to an integrative doctor to understand where you stand in this, both in terms of the biome, and we didn't talk about that. I could talk for an hour about the intestinal biome and the mouth biome and so on. But
Ahvie, we're going to get you back again and again until we get all the information that you have in your brain, and that's going to be a lot of webinars. Somebody was concerned about since a child is not as susceptible, or they could be positive. What are the risks of a younger person catching the virus, no symptoms, and passing it on to an older person, a parent, a grandparent, or somebody they come in contact with?
Well, that's the risk. The risk is relatively smaller if you're asymptomatic than if you're symptomatic. And there's the finite risk that exists in every situation. I mean, but understand that if in fact 300,000 positive tests in New York were done, and roughly 10 times that number of folks are really truly positive, this is going on every day. It's going on every day. So it is what it is. And if we had the ability to get this knowledge into the society, we would decrease the risk of having serious COVID complications across every age group. And then the youngsters can do what they please because the older population is already protected. Again, within that 65 age group, the pre-existing condition that isn't discussed a lot is the dementia also increases your risk of dying twofold. And so again, inflammatory states of all different types, are there. And of course, you can't control exactly what your loved ones are getting to eat in nursing homes, but at the same time, we have to get better at this. Our system is not designed for prevention, and we have to take it under your own control.
Right. Pat, do you have another question for Ahvie? Can't hear you.
All right.
Always, because Cubby wants to come on part of the show. So
Yeah, we have a webinar dog that immediately starts barking once the webinar goes on.
as soon as it goes on.
Yeah.
So what about the whole idea of we've got school going out and perhaps not going back in August, or if so, do we look at the possibility of children who've been exposed and or have been quote unquote carriers or had no symptoms or anything, actually acting as harbingers and to infect adults around them that are not their parents?
Yes, of course. Of course, this is the reality of life. The reality of life is the virus is here. The good news is that it does not make young folks sick. The regular influenza does, and the regular flu does, and kills kids, and this doesn't. And the Spanish flu killed the younger folks more than older folks. So this particular way that this particular virus works, it just can find those folks who are most susceptible, and it spares the youngsters, which is great news on the one hand. On the other hand, we do have to mix together at some point, and unless you're willing to wait for what will be a very challenging type of vaccine to make, then we have to accept this risk.
So could the possibility of sending the children back to school help build social herd immunity?
I mean, I'm not a herd immunity person, but I doubt that it would reach the level. But if you can get 200 million people to go back into the society because they're under the age of 55 and with relatively small risk, then you may be able to reach it. Yeah. I mean, I don't have an expertise in that, but I think Sweden isn't getting close to there either, even though they left themselves relatively open. But again, social distancing is the opposite of what you want to do if you want herd immunity. So.
Thank you so much.
So I would just like to leave everybody who attended this webinar and thank you all for attending. If you are a practitioner and a integrative physician, and you're not an ACAM member, you should become an ACAM member. And if you're a dentist and you're not an AAPMD member, you should become. And whether you are a physician or a dentist, find some other practitioner. If you're a dentist, find a physician to work with, and vice versa, because that we have a different objective, not to find a vaccine but in order to take this message of prevention to the entire population throughout our country, and we can do it by spreading the message about and let people take charge of their own health and build up their vitamin C, their vitamin D levels, and normalize it. Early on, when this came out, I was suffering from something which was probably COVID, and it was through didn't even have access to get into a physician's office, but Ahvie gave me advice, check my vitamin D levels, some IM vitamin Ds, and in 2 or 3 days, it would completely turned around. and even was taking the hydroxychloroquine, even though, you know, it was said to cause cardiovascular problems. I don't know whether I told you this, Ahvie, but
Yes.
I suffer from some AFib and arrhythmias. After the third day on hydroxychloroquine, I have never had another irregular beat.
Yeah.
So I am a study of one. But
Well, you know, we just sort of felt the risk benefit was worth it. And another startling thing that's happened, just for everyone to know, is anecdotes all over the country of people who had the virus and have recovered. Some more you know, some took longer than others, you know, but they feel better than they did before they ever got sick.
Mm-hmm.
So maybe it's because you can't eat very well and you go into a fasting mode, or it's something to do with how it resets your own ACE2 receptor permanently, and you just feel better. So I think that this has been the case even for folks who've been out of pocket for 2-3 weeks.
So we're so lucky to have you as our physician leader of our Collaboration Cures movement, and these updates are so invaluable and inspiring. It's informative and inspiring. So we look forward to the next one, and we should plan it sooner so that we can get the word out to many more people. There should be hundreds of people listening to this information.
Well, we need to empower ourselves, really.
Right, and so that's good. So thank you all for coming, and I always allow Pat to have the last word. Pat, are you there?
Can I sneak in real quick, Dr. Hendon?
If you have to.
So all attendees who are taking this to get some CE credit, I'm going to shoot the link. It's going to be a redirect option for you following the webinar. And if not, then you'll receive a link to the survey with the video recording within the next 2-3 days. But that's all I have for you. So Dr. McBride.
And we should just
Thank you.
thank Jordan, our wonderful producer.
Our MC.
Jordan, thank you.
Thank you for putting this all together. And good night, everybody. Pat, last
Bye.
word.
Yep. Oh, thank you for all coming, and we want to see you back again. And Dr. Herskowitz, we're counting on you for that next seminar. So get the next set of slides ready. We'll have you back soon.
Bye.
All right.
Take care.
Jordan.
Bye-bye.
All right, gentlemen. See ya.